All right, hello everyone. As mentioned, I'm one of the pediatric cardiologists. And so the first question you might ask, does HCM even happen in children? And just because you have the genetic mutation, as was pointed out, doesn't mean that you're going to get hypertrophic cardiomyopathy. And typically what we see is that it's less common, we see it less commonly in children than in adults, because it usually develops late adolescence, adulthood, although we do see some children, even as young as infants, develop that left ventricular hypertrophy before the typical age. Now, the key is that many children actually have the potential for hypertrophic cardiomyopathy in the future. And so any child that is a first-degree relative, so if their parent has HCM, if their brother or sister has HCM, they are at risk. And any child with a genetic mutation, maybe they did the genetic testing and they found one of those mutations, and we know that they are at risk for HCM, but they might not necessarily develop it. And so not all children who have the potential for HCM will actually go on to develop it, but we really don't know who's going to get it and who's not. And so just because you have the gene doesn't mean you're going to develop hypertrophic cardiomyopathy. Just because your father developed it at age 65 doesn't mean you're going to develop it then. You might develop it at age 40. You might get it at age 12. We really don't have a great way to know. And so for that reason, we just keep track of them, we monitor them, and a lot of the monitoring and treatment is pretty similar to what we do in adults. There's some minor differences that I'll go into because some treatments are not studied or approved in children. And then we also need to consider that whatever treatment we start in these people, it's going to affect their entire lives. So if you get diagnosed at age 60 and you start a medication, we say, oh, you have to take this for your whole life. It's not as big a deal as if you know that you're going to have college, adulthood, pregnancy, your first job, all these life changes ahead of you. So who needs to come see us? So first of all, anyone who has signs or symptoms that are concerning for hypertrophic cardiomyopathy. And so these are mostly symptoms with exercise that really get us concerned. So chest pain, shortness of breath, beyond what you would expect with exercise, passing out with exercise, that is never normal. Or sometimes a child or adolescent will get an electrocardiogram and it has some signs that are a little concerning for hypertrophic cardiomyopathy. We want to see those patients. And then heart murmurs, some of them can be innocent, some of them can be hypertrophic cardiomyopathy. Very difficult to tell unless we do some extra testing. But in truth, those patients, a lot of them don't turn out to be hypertrophic cardiomyopathy. We do see a lot of patients who have relatives with hypertrophic cardiomyopathy. So again, as Brianna mentioned, once a family member is diagnosed, specifically a first-degree family member, mostly a parent, sometimes a sibling, we definitely want to see that child or adolescent to make sure they don't have hypertrophic cardiomyopathy. And then thereafter, we want to see them at fairly regular intervals to just make sure they don't develop hypertrophic cardiomyopathy. And I think Brianna already showed this picture, but basically, let's see if I can figure out how to do this. Where's my pointer? Here we go. So for if children and adolescents who have a known gene mutation in their family, we want to see them every 1 to 2 years just to check if they're developing hypertrophic cardiomyopathy. During childhood, there's a lot of growth, not just in the body, but there may be growth also in the heart, and we want to make sure there's not excessive growth that would be consistent with hypertrophic cardiomyopathy. And then any other child or adolescent who has a family member diagnosed with HCM, we want to see them every 2 to 3 years. So what do we do when we see these children who have a family member with HCM or have a genetic mutation with HCM? So a typical visit, we ask about any symptoms, do a physical examination, listen for one of those heart murmurs that may be consistent with HCM, electrocardiogram, and importantly, the echocardiogram. And on the echocardiogram, we're really looking at the thickness of the heart, as Dr. Madrazo mentioned. And we're measuring the thickness in the heart, and in adults, a thickness greater than 1.5 centimeters is going to be diagnostic of HCM. If you all have a family history of HCM, it'll be greater than 1.3 to 1.4. Obviously, those numbers don't really work in a child whose heart is going to be much smaller. And so in children, we use something called a Z-score. And a Z-score is kind of like a percentile. And this is kind of the bell curve you may have seen so many years ago in your math textbooks. And so a z-score of 0 is average. That's just the average thickness of the heart. And once you get to 1 and 2 z-scores, you're getting up to quite a high number. And so, for example, a z-score of 2.5, which is what we consider diagnostic for HCM or concerning for HCM, that is the 99.4th percentile. So that means your LV wall thickness is greater than 99.4% of all people who have the same height and weight as you for a child. And so that z-score is kind of our cutoff where we're kind of getting more concerned about HCM. But if there's a family history, we have a little bit of a lower threshold, and we use a z-score of 2, which is that your LV wall thickness is greater than about 98% of other people. So it's a little trickier, and sometimes we have to just track these numbers over time to make sure that the LV wall thickness is not getting increased. Brianna did a great talk about genetic testing, and really, this is really useful to predict a child's potential to develop HCM in the future. So if a first-degree relative, say a parent, has a known mutation for HCM, then we can test the child for that specific mutation. Now, if we get a positive result, the child has a mutation, it doesn't really change all that much about what we do because the child was already being seen regularly to see if they have HCM or not. But if the child does not have the mutation that the parent has, that actually is pretty useful because we know that they are theoretically not at risk for HCM. And so the use of genetic testing for the child is to know to opt them out of further testing. So if we know that this mutation caused HCM in the parent, and we test the child and they don't have it, then we can say you are not at risk for HCM, and they don't need to see us anymore. Unfortunately, sometimes we test the parent, they don't have a known mutation for HCM. That's that 60% of patients don't really have a clear mutation. And so the genetic testing in the child won't really help because we don't really know what's causing the HCM, and so we're still going to have to see them every couple of years. All right, so if a child is diagnosed with hypertrophic cardiomyopathy, what do we do at the clinic visits? It's actually pretty similar to what we do with the screening visits. Check for any symptoms, do an exam, do an electrocardiogram to look for abnormal heart rhythms, which can sometimes happen, and then do an echocardiogram. Even though we know that they have hypertrophic cardiomyopathy from the prior echocardiogram, we're looking for worsening. So worsening of the hypertrophy or the thickening, worsening of the outflow obstruction or difficulty of the blood getting out of the heart. We want to look at the squeeze of the heart. Usually that is normal or actually increased, but if we see decrease in that function, that's a concerning sign. And looking for regurgitation or backflow of the mitral valve, which is the valve on the left side of the heart where the hypertrophy is. Some other tests we might do are similar to those in adults. So a Holter monitor, which is the wearable ECG, that's to look for abnormal heart rhythms that might happen. And so some of you may remember these complicated ones with you have electrodes all over your chest, you have this little Walkman thing, you have to walk around with this. Really annoying, but now fortunately we've moved over to these very small portable devices that are the size of a coat button, which is really useful for us in pediatrics because if you're trying to put this on a 2-year-old, they're not going to keep this thing on. And so these are really, it's really nice that they're miniaturized now. Once they're old enough to walk or run on a treadmill around age 7 or 8, we start doing exercise stress tests or exercise stress echoes. And then cardiac MRI, which a lot of adults get, it's not as useful in children just because this kind of scar pattern that can develop in the heart, first of all, we don't really see it early on. And there's not a clear link between the amount of scar and the risk of sudden death until you get to age 16. Those studies have just not been done yet. So we don't usually do cardiac MRI on pediatric patients. The treatments are pretty similar to adult treatments, and the goals of treatment are to treat the symptoms. There's not yet a clear way to prevent hypertrophic cardiomyopathy or to slow the progression, although I'll talk about some promising research in that area. Right now, it's mostly about treating symptoms. And as Dr. Madrazo mentioned, there's 2 kinds. There's the obstructive kind, where, where the blood cannot get out of the heart. And some treatments for that are Beta blockers, those are the medications that end in olol, metoprolol. Calcium channel blockers are a second choice. And then a distant third choice is something called disopyramide. That's, I feel, fallen out of favor a bit because of this new medication, Camzyos or mavacamten. Unfortunately, it is not approved for pediatric patients. It has not been studied in that population, although they're currently undergoing clinical trials for ages 12 to 17. So that may be an option in the future. One of the limitations, though, is that this is not approved during pregnancy. And so even when it does get approved for those 12 to 17-year-olds, we have to think about what is going to happen later on in their life. So if they do want to get pregnant later on, they have to come off the mavacamten. Is their HCM going to get worse? We're going to have to treat them with something else? And so right now for pediatrics, if we get to the point where we would institute mavacamten, but obviously it's not approved yet, we would go to surgery. And I think there's a talk later on about what's involved with surgical myectomy. Treatments for hypertrophic cardiomyopathy where there's not obstruction or difficulty with blood getting to the heart, pretty similar to adults. Again, those beta blockers, the medications that end in olol, calcium channel blockers, and then sometimes some diuretics. So this is the key question, and we know some of these patients have the genetic mutation that might lead to hypertrophic cardiomyopathy in the future. Is there a way we can prevent this? And so some researchers created a mouse model of hypertrophic cardiomyopathy. They basically created those mutations in mice to see if they could make a mouse with HCM, and they did, and they found that there's this molecule called TGF-beta that's involved in progressing to hypertrophy. And they also saw that this medication, losartan, which is a common blood pressure medication, actually blocks TGF-beta. So they treated those mice with losartan, and they found that actually they were able to prevent mice from getting hypertrophic cardiomyopathy by treating them with this medication, losartan. So this is a slide of a heart with a mouse with no treatment. This is a mouse treated with losartan. All this blue stuff here, this is all scar that happens in an HCM mouse. And you can see there's no scar in the mouse treated with losartan. So then the thought was, okay, well, let's try this in humans. So this led to something called the VANISH study, which was recently completed. And don't worry about that complicated graphic, but it was recently published a couple of years ago, so you can look this up, valsartan in early stage hypertrophic cardiomyopathy. And what they did is, and we were a center here, we recruited a couple of patients. We looked at 150 people with a known mutation for HCM. We know that they have the potential to develop HCM. And it skewed younger. The initial thought was to get more like age 8 to 25, but it was just very difficult to find a lot of people for that, and so it kind of got broadened to 45. But the key here is we wanted to look at people who had very little or no evidence of disease. So no or minimal hypertrophy, no or few symptoms, and no obstruction. And the idea was half of those patients would take valsartan, which is a similar medication to losartan, the one that was used in the mice, and half of those patients would have a placebo, and they'd take that every day for 2 years, and at the end of 2 years, we would see if there was a difference between those two groups. So at there were 3 different visits. So there was a first visit where everyone in the study had a cardiac MRI, an exercise test, an echo, lots of tests. And then 1 year after being on either valsartan or the placebo, they would get those tests again, and then after 2 years, they would get all those tests again. And the question was, well, how do we measure whether this slowed the progression of HCM? And the problem is that 2 years seems like a long time. It is a long time for a trial, but it's not that long a time for HCM, because you might have a very, very small change in your heart wall thickness, and it's a very short period of time. So it's very hard to measure those small changes. And so rather than looking at one specific measurement, like the thickness of the wall on echocardiogram, or the thickness of the wall on the cardiac MRI, or a blood test measurement, they said, let's look at all of these things together as almost like an HCM score and see if the predetermined HCM score gets better with valsartan. So did it work? Kind of. It was promising because that HCM score improved, but when we looked at the individual numbers, so the LV wall thickness, the cardiac MRI wall thickness, none of them really were that different between valsartan and the placebo. But it's not necessarily that it didn't work, it's just that maybe we just didn't look for long enough, there were enough people in the trial. So it's promising but unclear, and where does that leave us is that we just need more long-term research. And right now, it could be useful in people with early-stage ACM. I wouldn't give it to every single patient who has the genetic mutation for it, but if you have the genetic mutation and you're starting to get a little bit of hypertrophy, it's worth a try, but we have to balance that against the fact that you would have to take this conceivably every day for the rest of your life and never really know if it's working or not. It's a very well-tolerated medication, but if we don't know whether or not it works, it's a hard ask. And so I kind of leave it up to patients whether they're interested in that, knowing that we don't really know if it could work. It might work, and that'd be great, but we'll never really know. I'm going to move on now to lifestyle considerations because kids and young adults, they want to do a lot of things. And so we have to think about what kind of risks they might have with HCM. So I tell all my patients, stay well hydrated, especially in the hot weather with activity. And if you have medications, set a reminder, place your medications near your toothbrush because everyone remembers to brush their teeth every day, except my kids. Set alarms on your smartphone, use pill boxes, anything you need to do to remember to take that every day. And then avoiding heavy meals, especially for some of these teenage boys that really like to eat huge meals. And then even though I take care of pediatric patients, let's be realistic, they are going to be doing some of these risky behaviors, and they need to be aware of how this affects their HCM. And so excessive alcohol, other drugs, especially as they're going off to college, we have a talk about okay, you're going to go to college now, let's talk about what you might see there and how this is going to affect you differently than your other students. The other lifestyle consideration in children and young adults is sports and exercise. So this is what we all are worried about. You hear about all these events in the news, sudden cardiac death during exercise. A lot of times they don't say what happened, they just say, an athlete collapsed on the field. We don't really hear a lot of what that was due to. But the research shows that a decent number of those are due to HCM. And so it's really concerning, and for a while, the recommendations were, okay, well, if you have HCM, you shouldn't exercise, you should take it easy. But there's another problem with that, is that now we're going to be developing a generation of couch potatoes who are not developing these heart-healthy habits at an early age. And that can be just as bad, if not worse for you long-term than any risk here of exercise. And so now the recommendations are a bit more balanced, particularly knowing that a lot of these concerning outcomes were in patients who did not know that they had HCM. So once we know you have HCM, now we can actually do some testing and do some risk stratification to figure out what is your risk for exercise and what do we think you're able to do and what are the benefits also of exercise. So, and you can see the change and the shift in how we think about this in the guidelines. So back in 2011, the guidelines said, well, it's reasonable to participate in golf or bowling, it's fine, you don't have to, but you can. Or, you can do some basketball, just if you're just playing with your friends. But they were very conclusive. They said, patients with HCM should not participate in intense competitive sports. Doesn't matter how old you are, doesn't matter if you're male or female, doesn't matter if you have obstruction, doesn't matter if you had any surgeries done. It was just very categorically no. And over the intervening decade, we realized that, well, first of all, people are going to do whatever they want. We can recommend things. And it turned out when we researched those people who were exercising, they actually did better long-term than the ones who were not exercising. And so there's been quite a shift in the guidelines so that now, not only is it reasonable, but mild to moderate intensity recreational exercise is beneficial. It's recommended that everyone should exercise, even if you have HCM, with the caveat that you talk to your physician and make sure you know what kind of exercise is useful and less risky for you. And then if you have HCM, you want to be an athlete, you can have a comprehensive evaluation, talk to your physician, talk about the risks, talk about the benefits, and have a thorough evaluation, which might include exercise stress test, might include a Holter monitor, to see what is your risk with sports or exercise. The other clarification that was made in the guidelines is that if you have the gene mutation, again that word, genotype positive, but you do not have HCM on your echocardiogram, that just means you're at risk for HCM. It doesn't mean that you have it. So it's totally fine for you to play sports. And I follow a number of patients who their parent has a genetic mutation. We tested them. They have the genetic mutation, but their echocardiogram is fine. And so they have not developed HCM yet. They are fine to play sports. And now this is the change from before. Before it was they absolutely should not participate in competitive exercise, but now it's okay, it's reasonable after an annual comprehensive evaluation and shared decision making. And that means that, we're here to help you achieve your goals, and we need to talk about what your goals are and what the risks are. And now this is a complete about face from before where they said they should not participate at all to universal restriction from vigorous physical activity is not indicated. So in the last 10 years, we've kind of gone back quite a bit on what we were doing before. So in summary, if you don't have any HCM on your imaging, then you don't have HCM. So you should be able to do whatever you like after speaking with your doctor. If you do have HCM in imaging, you still should do mild to moderate intensity exercise, as it's beneficial. And if you want to play sports or do vigorous exercise, that's totally fine. After you discuss with your doctor, you have additional evaluation, and that may include an exercise stress echo, a Holter monitor, and then thinking of other things. And so for children wanting to participate in high school sports, we ask, okay, is anyone you're with CPR trained? Is there an automatic external defibrillator in the school? And then recommend that you always train with a group rather than alone. And then I tell all my patients, yes, you are cleared to play sports, but you need to tell me if you feel anything unusual during exercise. All right, thank you very much. I just want to acknowledge my colleagues, Dr. Carmel Bogle and Dr. Bill Ravix, and then just want to provide some gratitude to some of these other cardiologists who some of you may know from before. Ann Murphy led the HCM program for many years before she retired a few years ago. And then Dr. Reed Thompson, who is trying to retire, but we're trying to string him along for as long as we can.